Hello, nursing scholars. This is Bradley Geckner. I'm one of the professors here at Lewis Clark State College. Today I'll be giving a lecture on medication administration. Um, Medication administration is most likely one of the most common tasks or interventions that nurses do. It's also probably one of the most nerve-wracking and most dangerous interventions that you do as well. So as we go along here, there'll be quite a bit of information about patient safety. This is not a pharmacology class. This is about the medication use process and administering medications by all the different kinds of routes that are available and some of the nuances of those. But it's part of our safe nursing practices that we are knowledgeable about these medications. We understand the interactions with other medications, the side effects, the contraindications, and any other interaction that can occur with food or other medications. There are also some ethical things that go along with this as well, and some considerations that apply to medication therapy. Medications are substances that can prevent, improve, or reduce the symptoms of a medical condition, and the objective of drug therapy is to provide maximum benefit with minimum harm to the patient. When we speak of medications and medication labels, the chemical name describes the elements of the medication's molecular structure. The official name is assigned by the U.S. Adopted Names Council, and it's usually the generic name, which is simpler than the chemical name. Some of the chemicals are very hard to pronounce. The generic name is not capitalized and is oftentimes contains a prefix or a suffix, which helps identify the drug class. For example, beta blockers are drugs that are prescribed for cardiac conditions, and their generic names frequently end in OLOL, like propanolol, metoprolol, labetalol. The trade name or the brand name is a registered name assigned by the drug manufacturer. Because one type of medication can be manufactured by several companies, it can have several different trade names while still having a common generic and chemical name. This is just a medication label, and as you can see that Augmentin is the trade name, and then this is actually a combination drug of amoxicillin, and as you can see, this clavulonate potassium, that's a pretty tough word to pronounce. And then there's a bunch of other stuff on the label that is helpful to us, like the storage, how to mix it, how to reconstitute it, and so on and so forth, and also the concentration of the drug. And this is just an example. Medications are synthesized in a laboratory, or they're usually developed from a plant, a mineral, or animal sources. The United States and many other governments have developed standards to ensure uniform quality so that the effects are predictable, which is what we want. We kind of want to know what that medication is supposed to do and what the effects are going to be when that person takes the drug. So it's important that these are safe. The United States Pharmacopoeia, which is also abbreviated as USP, since about 1820, in combination with or in collaboration with the National Formulary, help protect public safety by identifying medication properties that show an appropriate range of quality and purity. The Pure Food and Drug Act of 1906 designated the United States Pharmacopoeia and the NF as the official authorities to establish drug standards, including the requirements that medications be free of impure products. Subsequent legislation has continued to set standards related to the safety, the potency, the sale, the distribution, and efficacy of medications, and the regulation of controlled substance, which we'll get into here a little bit later. The FDA mandates that all medications undergo safety testing prior to being released to the public. This would be something to think about when we think about meds and how much they cost. Most drugs, it takes millions of dollars to get them off the ground, and then even just to go through clinical trials and to determine that they're safe for consumption by humans. Within the United States, the Comprehensive Drug Abuse Act and Control Act, known informally as the Controlled Substance Act, established basically 5 categories of scheduled drugs, and these are all referred to as controlled substances. One objective of the Controlled Substance Act is to reduce the opportunities for drugs to be diverted from legitimate sources to drug abusers. So these are basically based on drugs that, on their level of, or their potential for being addictive. To track the use of these controlled substances that originate from legitimate sources, a written record is required for all transactions involving controlled substances. An inventory must be kept of all controlled substances in stock, and this inventory must be reported to the Drug Enforcement Administration every 2 years. Although not required, many hospitals and clinics require that floor stock of controlled substances be accounted for at the beginning and at the end of each nursing shift. So you may hear the word narcotic count, and that basically means that 2 licensed professionals, typically nurses, go through and count all of the narcotics. Now, with a lot of the new medication dispensing systems, sometimes that is already rolled up into there. And these have to be locked up as well. There are many reasons a controlled drug may need to be wasted. For example, if you have an order for 4 milligrams of morphine and it comes in a 10 milligram stick, or what we call an ampule, then you would have to waste 6, and that has to be witnessed by 2 licensed nurses. And oftentimes we squirt it into the sink or squirt it into the trash can, whatever the agency's policy is. But all of any dose or any amount of that medication has to be accounted for. This next slide, it just shows basically the schedules of controlled substances. And as you can see up here, a Scheduled 1 basically is all of the things that really don't have any accepted medical use. Heroin, LSD, those things don't really find their way into a hospital and aren't used to cure or treat any patients. You will see, starting with a lot of our narcotics, our morphine, our codeine, methadone, and methamphetamines that we use, those would be a Schedule 2. And then, as you can just see, it keeps going down and to the very low potential for abuse. So I would take a good look at that, this chart here, and at a minimum understand that there are schedules and what the schedules are and what types of medications fall into those. The goal of these regulations is to prevent adverse patient outcomes, obviously. So healthcare facilities cannot modify or expand the Nurse Practice Act. So violations of these regulations can result in fines, imprisonment, and unfortunately it can cause a loss of your licensure as well. So understanding these processes help the nurse evaluate the therapeutic or intended response, as well as any other unintended or adverse effects caused by the administration of these drugs. Pharmacokinetics is the study of how a medication enters the body, how it moves through the body, and ultimately leaves the body. And then the pharmacodynamics is the process in which a medication interacts with the body cells to produce whatever type of biological response we are searching for. To achieve a therapeutic effect, medication must be taken into the body. It has to be absorbed somehow and distributed into the cells and the tissues, and then alter the physiological functioning. Laboratory and diagnostic studies measure medication effects, and the effectiveness is affected by the medication dose, the route of the medication, the frequency of the medication, the function of the metabolizing organs, such as the liver or kidneys, which is where the majority of medications are metabolized. So we have to keep all of that in mind when we're talking about medications and the principles of drug actions. Several factors affect absorption. Like I had just said, the route of administration, the ability for that drug to dissolve or become soluble, blood flow to the administration site, body surface area, the patient's age, all of those can affect absorption. Administration of a medication intravenously, for example, or directly into a blood vessels, you would believe results in the quickest rate of absorption, followed in descending order by intramuscular, we give things subcutaneously, and then by oral administration of medications. So the route obviously has a lot to do with that absorption. Distribution is affected by the chemical properties of the drug and the effectiveness of the cardiac system, the ability to pass through the tissue and organ membranes, and the extent to which the drug binds to proteins or accumulates in fatty tissues. Those can all affect distribution. Products of this process are called metabolites. So most metabolism, like I had just said, takes place in the liver. It also takes place in the kidneys and some other place, but it may be slowed in elderly individuals or anyone with impaired liver function, for example, or impaired kidney function. Care is taken to administer these medications to these populations, as toxic levels of medications can build up if the liver is not able to break down the drug to a less active form. And then it just continues to accumulate, and it continues to exert its effect on the tissues and affect the person's physiological functioning. Most metabolites exit the body through the kidneys, but some may be excreted in feces. We also lose some through our breath, like alcohol, saliva. It can be excreted in sweat and breast milk. Levels of the drug may be accumulated in the elderly individuals and persons with impaired kidney function, like I had said, which kind of necessitates the prescription of smaller doses with a longer duration between doses. So those are the things. Elderly, there's two spectrums. There's the elderly and the really young. And when we start talking about medications, the age of the patient has to be a factor to consider when we start talking about the doses and how often they're going to get the medication, based on how their body is going to break down and react to these medications. Some people I know are really visual learners, and for me, I'm a real visual learner. So if to put all of that kind of in context, you can see in this example, it's a capsule, and they're taking a capsule and it's going down, it's getting to the stomach, it's going down through the small intestine and large intestine, and it's getting absorbed and out, and then it's metabolized by the liver, and then it's excreted in, like we said, either in feces or in the urine. Pregnancy is a big thing when we're talking about medications. Nurses have to take extreme care when administering medications during pregnancy. And this is especially true in the first trimester due to the risk of the harm to the developing fetus. Effective about June 30th, 2015, the U.S. Food and Drug Administration requires labeling of all prescription drugs and biological products to include a summary of the risks of use during pregnancy and lactation. A lot of that has to do whether they cross the placenta barrier and whether or not that's going to end up in breast milk and then be passed on to the child. Age-related changes, including increased fat deposits, decreased gastric mobility, decreased renal and liver function, and changes in the blood-brain barrier can lead to increased side effects of medications. And we also have certain cultural and religious groups that have beliefs that discourage the use of medications other than natural remedies. So we have to consider all of these during any kind of drug administration and what types of drugs we're using. Systematic responses include those seen when a pain medication is administered that impacts, for example, the nervous system, and then we end up with some sedation. We also end up with an effect on the respiratory system, which we get a decrease in the respiratory rate. And the GI system, for example, narcotics typically are known to cause constipation, therefore we give things like Colace and laxatives to help prevent that. Example of local responses include when an anti-pruritus lotion is applied to an insect bite. That's an example of that. Improvement is generally seen when a therapeutic effect is achieved with the medication, but unexpected or unwanted effects may occur, and we know what some of those may be, and different patients may respond differently to the same medication. So each patient can be a little bit different. The desired drug action is produced by maintaining a constant drug level in the body and is based on the half-life of the drug. Repeated doses are usually required to maintain the desired drug level. Correct spacing of doses to maintain consistent drug levels and obtain therapeutic effects is an important consideration when medications are prescribed. The onset is affected by the administration route, the drug formulation, and the pharmacokinetic factors that we just discussed. For example, the onset action for insulin varies greatly depending on the route, whether we give that intravenously versus subcutaneously, and on the type of insulin as well, which would be your fast-acting Humalog versus Lantus, your long-acting. Once the peak is reached, serum levels will decrease until another dose is administered. The peak and the trough levels of medications are measured with serum laboratory tests and are used to adjust dose amounts and monitor for toxicity. Peak serum levels are drawn at specific times after administration on the basis of the drug half-life, and trough levels are drawn just prior to the administration of a scheduled dose. Vancomycin is one of those drugs that this is pretty common with, where we'll draw a peak and a trough. So before we give them, 30 minutes before we give the medication, we'll draw it, and then 2 hours after that, we'll draw it again to determine what the peak is. So the trough is the end of the medication onset and duration of the medication. So we would take the peak after the half-life of that medication, in this case in vancomycin, to be about 2 hours. And then 30 minutes before we give that vancomycin again, we'll take it again, which will show us what the trough is, or the lower level. And if it needs to be adjusted, then we'll adjust it based on those serum levels. Again, this is just a visual to show what we had kind of just talked about. And if you look here, we're talking about an onset of 30 minutes, which is right here. So we should start to see things with whatever drug this is, the onset, we should start to see effects within 30 minutes. And then the peak effect will be in 1 hour. And obviously that's probably somewhere around the half-life, if you look at that. And after that, we begin to go down and down and down until we reach a minimum effective drug concentration, which is 10 milligrams per mil. And the whole time from the onset all the way till the minimum effective drug concentration is a direct duration of action. So the drug is doing something within the system, and oftentimes many of these things, this says the duration of the action is about 2 hours, but depending on that, if we put another dose on here, it'll do the same thing all over again. Side effects, they can be minor, and or they can be harmless for that matter, or they can cause patient injury. Patients may refuse to continue a medication because of these side effects. patient education regarding on how to handle expected side effects can offset such reactions. So nurses must be particularly alert for these side effects when a new medication is started or the dose is increased. An adverse effect may occur after one dose or may develop over time. So when an adverse reaction occurs, the medication is immediately stopped. So if an example of this is like if we're giving someone Ancef, for example, which is a cephalosporin, and there are some people that are also allergic to sulfa drugs that are also allergic to Ancept and penicillins, and so there are some crossover sensitivities that occur. But if I'm giving that to the patient and in the next 20 or 30 minutes they tell me that they're kind of itching and then they have a rash on their body and then they start having difficulty breathing, the first thing I need to do is stop it. That's the first thing. So stop it, and then we need to monitor the patient, get on the phone, find out what's going on, and then get whatever drugs we need to counteract that. Maybe some Benadryl might be one, and then I will probably be also looking for some epinephrine to have handy if this reaction continues to get any serious and she starts to have anaphylactic reaction and can't breathe. And these adverse reactions are reported by healthcare providers to the FDA using what we call MedWatch, a MedWatch program, which is just a drug reporting system. Toxic levels of a drug can lead to serious physiological effects. They can be lethal. Organs that can be damaged from drug toxicity, like what we talked about, include the kidneys, the liver, and organs of hearing. Ototoxicity, again, we were just talking about vancomycin, and that's one of the adverse effects of vancomycin is I would inform my patient, please let me know if you have any ringing in your ears. So we can also educate patients on what some of these common things are, and they can be our ears and our eyes for the drug therapy that we're giving them, and we just have to make them aware of those. However, most drug toxicity is pretty much avoidable with careful patient monitoring and obviously monitoring the kidney and the liver functions. Drawing those types of tests will also tell us how their body is reacting to this medication. So when a patient is first exposed to a foreign substance, which we'll refer to that as an antigen for now, the body produces antibodies against it, and then the medication, which is a chemical preservative, basically, or one of the metabolites, can initiate the immune response. With exposure, the patient reacts to the antigen with an allergic reaction that ranges from minor to severe. So I mentioned to you earlier about a minor allergic reaction would include a rash, itching of the skin, maybe some inflammation of the nasal passages and whatnot. That is the onset of something that can be really serious, but I personally am not going to mess around with that. If I start to see any of that, that's going to be stopped immediately, and I'm going to notify the provider. A severe reaction, which I referred to earlier, is called an anaphylactic reaction, and that is a medical emergency. And that can occur immediately after administration, or it can occur a little bit later, and unfortunately that can be fatal. So when we give medications, one of the things that we hound on, or I hound on, is you should always ask a patient, and I don't care how many times you do it, before I give a medication, one of the questions should be, are you allergic to anything? Are you allergic to latex, adhesive, shellfish, avocados, bananas, or any other substances or medications or herbs? We want to know everything that they're allergic to, because some things that people are allergic to do have bad reactions with drugs. And patients who have experienced a severe allergic reaction to a medication really need to wear an identification bracelet or a tag identifying that drug or substance. The bracelet or the tag alert medical alert staff that the patient is allergic to something, and this is especially helpful if the patient is unable to communicate. In the hospitals, obviously, we ask them as well, and that is why that's so important to ask them, is that if they don't have a bracelet on in the hospital, if they are allergic to something, there will be an allergy armband on them, and that is very crucial and very important. An idiosyncratic response can be either an over response, or an under response, or abnormal reaction to the medication. Basically, that just can't be explained. A medication interaction can be altered, like we've talked about already, the way the medication is absorbed, the way it's metabolized or eliminated. A synergistic effect occurs when the combination or the combined effect is greater than the effect of either substance if taken alone. So there are several drugs that, when giving together, work synergistically and bring a better effect or a bigger effect than if they were taken alone. And a synergistic effect may be specifically sought by the healthcare provider. It may be something that we really do want to happen. But sometimes it can also be an accident, and we end up with a little bit more than what we've bargained for. So special care is taken when administering parental medications. We talk about compatibility. That has to be assessed before mixing or administering medications with the syringe through intravenous tubing. We worry about compatibility, we worry about the rate of administration, we worry about dilution and some of the other things, especially when we're dealing with parental medications, which we will be getting into later. The FDA regulates OTCs, or what we call over-the-counter medications, relative to the safe and recommended dose, but it does not regulate all the supplements. So most of your supplements have not been through the FDA, and if you look really small on there, on a lot of your vitamins and your minerals and your herbs, will be something on there that says that this drug has not been proven by the FDA to cause whatever it is that herb or that vitamin is supposed to do. The FDA has basically developed a checklist for use when selecting these over-the-counter medications. The vitamins needed by the body are usually acquired just basically from the food that we eat. The body uses these vitamins for the biological processes of growth and digestion and even our nerve function. Water-soluble vitamins are excreted by the body through the kidneys, and fat-soluble vitamins are stored by the body for use as needed. However, an excess can build up in the liver, so they must be used with caution. Conditions in which vitamins should be considered for use include things like pregnancy, breastfeeding, a vegetarian or a vegan diet, an illness, or any other condition that prevents oral consumptions of foods, and the need for dietary supplements. So if they're not getting it through their normal diet and their normal nutrition, in some of these instances, it is recommended that we provide them with additional vitamins and minerals that their body needs. The FDA regulation of herbs is also different than that for prescription medications, despite the fact that herbs and prescription medications can act in the human body the same way. So what we need to really realize about all this is that the prescription medications that we are giving a patient, along with any of the other herbs or vitamins or chemicals that that patient's putting into their body, can have interactions. So the FDA regulates the herbs and dietary supplements through the Dietary Supplement Health and Education Act. But again, a lot of this stuff is not proven. So the takeaway would be to, when we're doing our medication reconciliation, we're finding out all the medications that this patient is on, in that questioning we need to include besides any of the other medications, are you on any over-the-counter medications? Are you on any herbs? Are you on any vitamins? Are you taking anything special for weightlifting or protein drinks or whatever it may be? But we need to at least be aware of those because they can interact with drugs. Medications, true medications, are usually dispensed by a pharmacist. Um, that's their function, is for a pharmacy to dispense medications. Um, they can only do that after they receive written directions or the prescription. Um, it is illegal to dispense any type of medication without a legal prescription. And I'll show you an example of that here. The prescription has to contain the date, the time the order was written, the name of the drug to be administered, the dosage of the drug, the route of the drug, the frequency of the drug administration, and the signature of the person writing the drug. And many of them also have a prescription number. And here's an example of that. Michelle Graves, she's an RN, she's a family nurse practitioner. It's got the address up here, got their name. So we have the drug, we have the route, we have the amount, and we have the frequency, which is QAM, and we have the number of tablets. And then here's her DEA, her Drug Enforcement Agency number, which is right here. The chances of you seeing these nowadays are probably pretty rare unless you're taking a medication prescription from a clinic and taking it to a pharmacist, or they take it and they print it out. More oftentimes, it's just done electronically from your doctor's office or from the hospital. They say which pharmacy do you want to go to, and they forward it to that, with obviously all of these legal criteria met. So each patient in the healthcare setting has what we call a MAR, or it's more often referred to as a medical administration record. And what I want you to take away from that is that that's exactly what it is. It's a medication administration record. So it's just a record of what medications we're giving. These are not orders. So when you're looking at a MAR and you're comparing the MAR against the medication that you're giving, just remember that there should also be, in addition to that, there has to be a physician order or an advanced practice nurse order if they can prescribe in the state in which they're practicing. But you have to realize that just because it's on the MAR doesn't mean that there's an order for it. So keep that in mind. Computerized charting meets the majority of all of these requirements. And with technological advances such as barcodes and electronic administration records, which we call EMARs, CPOEs, which are computerized physician order entry, intravenous smart pumps, and clinical decision support systems, have been shown to reduce medication errors and prevent adverse events by providing legibility, nurse and physician reminders, and patient condition change alerts. Certain things that I would call hard stops, where if things are not right, the computer has a way of identifying those and flagging them. Unfortunately, with many of these systems, there's also overrides, so people can override them as well. Not only has it shown to reduce medication errors in some aspects, it has also reintroduced some other things that we need to keep in mind when we're talking about medication errors, which we'll get into a little bit later when we start talking about the medication use process. There is a difference between medications ordered Q6, which that means every 6 hours, and those ordered, say, QID, or 4 times a day. Even though 4 doses of the medication will be administered in any 24-hour period. A medication ordered Q6 is given around the clock at, for example, at 6 a.m., at 12 p.m., and at 6 p.m., and then again at midnight to maintain that constant blood level that we talked about earlier. So it's important for us nurses to know why we're given this medication and why it's ordered for certain times. And we just have to keep that in the back of our mind. A medication given QID, which would be 4 times a day, for example, that would be set up to do it at 9 a.m. and then 1 p.m. and then 5 p.m. and then 9 p.m. Is we want to try to administer those during waking hours. So that's kind of why those are set up that way. So we just need to understand what we're trying to achieve. Obviously, a sudden change in the condition, an adverse response to a medication, and a patient transfer to a different care unit can each necessitate a change in medication orders. So as we change from clinical areas to clinical areas, or as the patient status changes, we also change medications, we change how often they're delivered, maybe the doses, and so on and so forth. Insulin is kind of one of those that's often prescribed to be taken at a specific time before meals. Other medications may be ordered to be taken after meals to ensure that the food is in the patient's system. So those will be in when we're looking up a drug, and if you know, I don't know about you, but I'm not a walking pharmacopoeia. You have to be able to read and look up these drugs and know about these things, know about these times, know about the contraindications, know about the adverse side effects, know about whether they should take it on a full stomach or with food or without food, and understand why what's the indication for this medication. So, and we'll talk about those things when we start talking about the 5 rights of medication administration, or excuse me, 6 rights. So the 5 common types of medication orders typically in the acute care are based on administration frequency or the urgency. Things like routine, PRN, which stands for as needed. Sometimes you may see one time or on call. That happens for patients that are being sent to the, for example, to the operating room. We may say Anceft 1 gram times 1 on call to the OR. Or it could be stat, or immediately, or they could just say now, which is kind of the same thing. Stat medications, however, if you hear someone say stat, that means they are to be given immediately, right now, without pause and without delay. The nurse is notified of when to give an on-call medication, and the time is based on when the treatment or the procedure is scheduled. So whenever that person's surgery is supposed to start. And you may not actually give the Anceft or the antibiotic. You might just tape it to the chart, depending on what is going on. Antibiotics typically nowadays, the operating room is kind of my specialty. I worked in for 27 years or so, and things have kind of changed as to when we give that. And now typically we give those antibiotics as close to cut time as we can, within at least 30 minutes. So we don't want them to give that on the ward and then have them get down here, and what if their surgery gets delayed and whatnot. So we have to pay attention to what these orders are and what they say, so read them carefully. A PRN medication, like we said, that's kind of, we give those as needed. Let's see, what's a good example? Tylenol, for example. It may say give Tylenol, PRN, headache, or PRN temperature greater than 101.5, or whatever that may be. So this is just showing you the different types of orders that you may see. The bottom line for me is make sure that you read the order in its entirety and understand why that patient's getting the medication and why we're doing what we're doing. We talked about the MAR, or the Medication Administration Record. This is just an example that I found that you'll probably see more often than not, which is a computerized, an EMAR if you were electronic medication administration record that are in the hospitals. As you can see, it has all of the components. So you would have most of your scheduled meds would show up here, and then you have your PRN medications down here. Anyway, and different places are set up in different ways. So while the pharmacy should appropriately dispense the correct form of the medication, the nurse needs to ensure that that medication is in the correct form for the route of the administration that we're doing. Nurses typically are not responsible for things such as epidurals or your intrathecals or interosseous, intraperitoneal or intraarterial parenteral routes. Typically, those are an anesthesia function. The nurse is still responsible, however, for monitoring the integrity of the delivery of that system. So although we might not be putting medications into the epidural, it is our responsibility typically to make sure that it stays in the back where it's supposed to be, in the epidural space, and the tape and the dressing and all that is still up to us to make sure that we monitor and understand the desired outcome of that medication, and helping anesthesia evaluate the patient's response to the medication for everything. So if an epidural is for pain, and we ask them on a scale of 1 to 10, 1 being no pain and 10 being the worst pain that you've ever had in your life, and they give you a 7 and they have an epidural or an intrathecal or a spinal in, you've got to question, is that spinal in the right spot, and is it doing what it's supposed to be doing? Especially if they say that the pain is like in their knee, okay? Everything from wherever that epidural is down, typically from your umbilicus down, is basically none. So they shouldn't be having any pain. So, and that's part of what nurses do. We monitor that therapeutic medication, and we'll make sure that it's supposed to be doing what it's doing without harming the patient. PO is an abbreviation for the Latin term. It basically means per os, and os is mouth. So medications given by the oral route, like we've discussed earlier, have a much slower onset of action than parenteral medications that we would put in an IV, or even that we would give in IM injection, intramuscular injection. Patients without difficulty swallowing may hold medications in their mouths, or patients with cognitive or mental issues may pocket medications in the cheeks. I've had all of that happen. So be careful about giving the cup to the patient and walking out of the room. We want to sit there and we want to watch them swallow that medication. And if it's somebody who I have any doubts about, you might even ask them to go ahead and open your mouth for me and see if they've got it tucked away in there. So PO is the slowest onset of action. The sublingual and the buccal oral routes are used for absorbing small amounts of medication. The one that comes to my mind right away is nitro or nitroglycerin that we give people for angina. And that is a very specific delivery of medication that you have to put it under your tongue and hold it there. And it basically absorbs into the mucous membranes of the mouth, and then is distributed through the body. If the route is indeed sublingual and or buccal, okay, these are not to be chewed or swallowed ever. They're designed and made and tested to be given this specific way and only this specific way. Medications administered by the buccal route, which we talked about just a little bit here, those type of things I can think of are antiemetics typically, and or there are some opiate pain medications that are also given that way. Oral medications can typically be administered through nasogastric nasogastric tubes, gastric tubes, intestinal and jejunal tubes. The tube placement is always checked before we give medication administration, and there's ways that we can check to make sure that it's in the correct place. However, the only definitive way to find out if an NG tube or any of these other tubes are in the correct place is by an x-ray, period. So safety precautions need to be taken to make sure that it's in the correct place. And we also have to be careful about aspiration, or in the case of an NG tube, clogging the tube when administering medications, because some of them have really small bores, meaning a small tubing. So depending on the tube that you're giving, we typically always flush it after a medication to make sure that all that medication gets to where it's supposed to get. Of note is pretty important that not all medications can be crushed. Enteric coated, time release, like I mentioned, the sublingual and the buccal and other medications with special coatings should never ever be crushed and put through a tube. And again, we have resources. You're not a walking pharmacopoeia, like I've said before. So one of the things you could do besides a book or the internet or your drug formulary that your hospital uses, or your electronic pharmacy, you can also always call a pharmacist to get clarification if you ever have any questions. So if you do have any questions, please make sure and ask the question, because after you give the drug, it's too late. Nurses administer medications to the skin and mucous membranes also, and this is done in a variety of ways. Liquids and ointments can be directly applied to the eyes. Suppositories can be inserted into the rectum or the vagina. Fluids can be instilled into the body cavity, such as the ear, the nose, the bladder, the rectum. And body cavities such as the eye and the ear and the vagina and the bladder and the rectum can also be flushed with a medicated solution. A spray can be applied to the throat. What I think of that is like if you've ever seen an endoscopy, sometimes they'll spray what they call hurricane back there, which is a lidocaine spray to help numb that back there. That's a spray that can be used. And then there are lotions and ointments that we're probably all somewhat familiar with some of those that can just be applied to the skin surface and it's absorbed through the skin. And most of these topical medications, they require additional applications, and whether it says 24 hours or not. Things like nitroglycerin paste, there's also a paste that people that we used to put on people's chest. I mean, we put it in by the quarter inch or the half inch. It's like toothpaste, and you put it on their chest, and then you put a patch over it. And then in a certain time period, usually once a day, that will come off, and you wipe that down, then you apply the next dose in another spot. Those are just some examples that are coming to mind. Here's, again, I know you guys are all kind of visible learners like me. So this just shows how you give an eye drop. You should go from the inside of the eye out, and on kids you pull down and away, and on adults you pull up and away. And it's just showing you how they put cream on here. Just some pictures to kind of break it up. We are going to go through a couple more routes of medications, finish that up, and then I'm going to take a break, and we'll break this up, and then I will deliver part 2. So the inhaled medications, the deeper the passages of the respiratory tract, they provide a large surface area for the medication absorption. So this is a good, like your bronchodilators and things like that for asthma. Those are inhaled medications that basically help open the lungs. And if you think about your lungs and your alveoli and the little capillaries that are in there, there is a lot of surface area in your lungs. So And there are also some other drugs that you can give, like Narcan and Epi, and some of the other drugs that you can also give down, for example, an endotracheal tube, um, but you have to give twice the dose. But it does work and it does get there. And the means of delivery typically include small amounts of fluids because we can't just, you know, squirt a hose down someone's lung. So these are typically smaller amounts. They can be meter dosed inhalers, which is kind of what we're kind of focusing on in this particular slide. And there's turbo inhalers. And then there's nebulizers where we drop medications into a little receptacle and we force oxygen through it and it kind of creates a mist. And then they breathe those in as well. And those are called nebulizers. This just shows, if you look at an inhaler itself, here are all the pieces of all that, kind of shows you the internal mechanisms. Um, it is helpful when delivering this type of medication, especially for kids, to have what we call the spacer. And what happens is they push the button and it fills this chamber and then they breathe in and it goes into their lungs versus just putting this over their mouth and trying to get them to learn to let out all their air, squirt it twice or once, and then take in a deep breath and hold it. So this is particular, and also for your more elderly people that are just, for whatever reason, maybe not quite as coordinated. We want them to get all of that medication. So this is a spacer, or they also call it, I believe, a meter dosed inhaler is one of the other things that are handy for that. So now finally you guys are all want to become nurses, and probably one of the biggest highlights of your nursing education is going to be giving an IM injection, right? So I'm going to give you just a brief overview of some things regarding parental medications, but we will obviously be going over this more in lab as well. So the standard size syringes that you're going to see um, is a 1 cc syringe or tuberculin syringe, a 3 cc syringe, a 5 cc syringe, or a 10 cc syringe. Or I should be saying milliliters. I guess my age is showing how long I've been a nurse, but we used to call it CC and they stopped that. So now it's only milliliters. Subcutaneous injections, okay, are typically administered, okay, with a 1 mil syringe and about a 3/8 to a 5/8 inch needle. Intramuscular injections, however, are usually administered with a 3 mil syringe and a 1 to 2 inch needle, depending on your patient's size. We have to get to the muscle, so at a minimum a 1 inch, for at least for an adult anyway. And then there's intradermal injections, which I guess the most common thing that we could all relate to would be a TB test, which is why they call it a 1 milliliter tuberculin syringe, because that's what it's used for. And those can be a 1/2 inch to 5/8 inch needle. Insulin syringes are a special syringe that are calibrated in units and milliliters and are supplied in 2 sizes. So you have a low dose of 50 units and you have a standard dose of 100 units, each with a 26 to a 31 gauge needle. So they're really tiny needles. Insulin can be administered by a pre-filled insulin pen, which basically combines the insulin. If you had a regular and a long-acting or NPH insulin, that would be an example of where those could be mixed. A lot of things such as Lantus, your long-acting insulins, as well as your Novolog, which is your quick-acting insulin, those are also coming in pre-filled insulin pens where you just dial the amount of units that you want, and it's already got, you have to unscrew a needle and put it on each time, and then you just inject it that way. Going back to the slide just real briefly, you don't try to memorize the the object of this is not to memorize these, but to understand, at least on some level, if you're going to give an intramuscular injection, for example, you know, I automatically think of 3-1. So it would be a 3 milliliter syringe with a 1 milliliter, or, you know, 1 inch needle. And obviously, you know, if I could get away with, depending on the type of fluid that I'm injecting, you know, the smaller the needle, the better. So this says a 20 to 25 gauge needle, which those are fairly small. But you might have to go with an 18 or a 20, depending on the solution that you're giving. So we just have to keep those in mind. Over here, they're talking about the different sites for IM administration, and we'll be going over those, as well as going over how to find each one of these. What it's showing you is that the preferred site for infants is the vastus lateralis, and for children is the vastus lateralis or the deltoid, and in an adult, typically the ventral gluteal or the deltoid. I say go for what's easy and what's available, as well as how much solution you're putting in, because there are limits on that. So when we're talking about parenteral medications, we use what we call a filter needle, which traps any glass fragments. And these are typically when we're drawing a medication from an ampule, which is a small glass vial that you crack in half, and you draw the medication out of it. And to minimize the shards of glass that can get in there, there's basically a filter needle that we use to withdraw the medication out, and we throw the filter needle away and put on the needle that we want to administer the medication with. And that has to be done. Okay, you have to change needles. You can't just go start giving things with filter needles. That's not going to be nice. A lot of needleless systems are out there and available for intravenous medication administration, and they require special tubing and ports and blunt tip cannulas that attach to syringes in places of needles. And a lot of places have gone to what we would try to call, I would say, a needleless system, so that needles are kind of a thing of the past unless you're given an IM injection. So we used to draw things up in a syringe like you would give an IM injection, and then we would stick these needles into IV ports, and what was happening is people were getting stuck. It was going through the tubing and coming out, and it was kind of a mess. But to eliminate that, when we start to learn about IVs and IV medications and IV tubing and IV pumps, you'll see what we're talking about. But rarely will you have to use a needle for any of that. So we're going to go ahead and take a break now, and I will call this part 1, and then I will go in and I will start part 2, where we'll be talking about safe medication administration.